So let me share my screen. Okay, can you see my presentation?
Yep, I got it.
Okay. I'm Julie Percefull. Welcome to my presentation on improving mammography through effective screening, brief intervention, and referral to treatment at a rural health center. I've included a picture of Family Medical Center of Hart County where this project was conducted. Breast cancer is the most diagnosed cancer and fifth leading cause of death in women in the world. The rate of breast cancer diagnosis in Hart County is 7.3% higher than Kentucky and 14.3% higher than the national rate. The breast cancer mortality rate in Hart County is 59% higher than Kentucky and 67% higher than the national rate. In addition, breast cancer treatment costs reached $16.5 billion in 2010. The breast cancer screening rates in Hart County are 23% lower than Kentucky and 48% lower than the national rate. A chart audit at Family Medical Center of Hart County revealed that the mammography order rate was at 25%, with the completion rate of those mammograms ordered at 25%. 75% of patients' mammograms were not addressed at their last visit. Evidence-based guidelines were not used consistently among providers, decision aids were not utilized to engage patients, and processes were not standardized. Screening mammography rates are stagnant. If screening is not increasing, deaths are not being prevented, as screening mammography is the only method known to effectively decrease the mortality rate. Research has shown that electronic health records improve screening rates through automated reminders and providing an educational opportunity to engage patients. The rationale for this project was screening, brief intervention, and referral to treatment. Patients were screened to determine eligibility for mammography. Brief intervention occurred with the use of a decision aid. Patients were then referred for mammograms, and this standardized our processes. Right care was promoted with the use of the case management log, ensuring appropriate, effective care was provided to patients while preventing overuse and underuse. The aim of this quality improvement project was to increase the rate of screening mammograms and right care to 55% of eligible patients in 90 days. Family Medical Center of Hart County is a privately owned, high-volume family practice operating as a rural health clinic in South Central Kentucky. A quality improvement team was established for this project that included 4 nurse practitioners and the director of nursing, in addition to a pre-existing management team that assisted in implementation and balancing measures. Patients included in this project were females 40 to 74 years of age, primarily Caucasian, with 2% of patients being self-pay and the remainder of patients divided equally among Medicaid, Medicare, and private insurance. This project consisted of 4 core interventions and implementations conducted over 4 Plan Do Study Act cycles consisting of 2 weeks each. Screening with an electronic health record reminder identified patients eligible for mammography and allowed standing orders to be implemented. Patient engagement occurred with a decision aid assessing the patient's personal risk factors for breast cancer. The case management log promoted right care by tracking demographics, whether patients' appointments were missed or kept, and follow-up to ensure right care was attained. Team engagement through weekly team meetings assisted in implementation of the interventions. Data were collected through chart audits every 1 to 2 days to evaluate the use of electronic health record reminder, decision aid use and patient survey results, the provider mammography order rate and standing order rate, and right care components. Weekly data was collected from the quality improvement team agenda and staff and team meeting survey results. Aggregate data were compiled onto spreadsheets weekly, and this data was used to construct run charts which were assessed for special cause variation from the implemented interventions by monitoring for shifts or trends. Data was then analyzed at each compilation to determine effectiveness and subsequent interventions based on results. Each intervention had an operational definition that was evaluated through process and outcome measures. Process measures consisted of the utilization of the implemented tools, and outcome measures assess the result of the implemented interventions through surveys and mammography and right care rates. Quantitative data were analyzed 1 to 2 times a week for screening with the electronic health record reminder, engagement with the decision aid and patient surveys, the case management log and tracking of right care components, and team engagement and surveys. Qualitative data were utilized solely for identification of patients' personal risk factors and were not recorded or tracked. This project was excused from review by the Institutional Review Board at Frontier Nursing University as it does not qualify as human-subject research and meets federal requirements for quality improvement. No outside financial contributions were received for this project. Overall results showed improvement in each core intervention, with screening rates increasing 40%. The decision aid utilization increased 23%, with patient satisfaction in their mammography decision reaching 100%. Case management log utilization increased 54%, and team member satisfaction reached 78%. This run chart is the number of the patients screened with the electronic health record reminder and shows an initial increase in implementation, followed by a decline that persisted for most of implementation. Signs to promote screening mammography were posted in triage rooms, followed by staff simulation training on the use of the processes in an effort to increase utilization. Reviewing data with staff proved to be the most effective motivator, as evidenced by the improvement in the last cycle, with the median improving from 25 to 30%. The decision aid run chart again shows an initial increase in implementation, followed by a decline for several weeks. Use of the decision aid was spread to additional triage staff. A simulation training was conducted. However, improvement occurred by increasing patient access with placing the decision aid in the waiting room. This run chart compares the provider and triage ordered mammography, and it follows the same trends. Weekly rewards were initiated to increase staff engagement and use of tools, but reviewing results on the use of the processes proved to be the most effective. The chart supports how effective use of the standing order is at increasing mammography rates, and when standing orders are used consistently, mammography rates surpass the state screening rates of 59%. The decline noted at the end of implementation resulted when the electronic health record reminder was changed for providers and triage staff to have separate reminders, resulting in decreased utilization. The team engagement run chart shows use of the QI team agenda. It remained fairly consistent with the median at 78%. Research supports use of rewards and review of outcomes as utilized in this project to promote team engagement, cohesiveness, and work toward a common goal. In this project, 413 patient charts were screened, with 78 patients identified and tracked for right care. Screening with the electronic health record reminder rose to 40%. The standing order rate increased from 25 to 29%, with patient engagement rates increasing from 20 to 26%. Patient confidence in their mammography decision reached 100%. The combined mammography rate increased to 35%, and team engagement reached 100%, proving that these processes that were implemented are sustainable. Research has shown that an electronic health record standardizes screening, appropriately identifies patients eligible for mammography, and automatically updates with preset criteria. It also reduces the chance of missed opportunities. The decision aid effectively engages and empowers patients to take a role in their own health care, and this proved to be accurate throughout this project as increasing patient access to decision aids increased utilization. The case management log effectively captured all patients tracked for right care, confirming no disparities existed. The low rate of the utilization of the tools limited the quantity of right care. An unanticipated low rate of team and staff engagement occurred during this project, and research shows that use of extrinsic rewards, such as review of data on utilization rates and working towards a common goal, result in higher outcomes in performance. Family Medical Center of Hart County has the ability to create reminders with preset criteria and utilizes triage staff to initiate patient visits and address electronic health record reminders. This creates a unique opportunity for staff to implement standing orders. During this project, limitations likely occurred from staff discord, resulting in a potential bias toward the use of processes and incomplete data collection, affecting the validity of the data. The screening mammography and right care rates were effectively increased at Family Medical Center from 25 to 35% of eligible patients in 90 days. Processes were standardized, lending to effectiveness and sustainability. Subsequent steps include continued utilization of implemented processes, ongoing monitoring of mammography rates, and potential spread to additional preventive health measures. Team engagement will continue through review of monthly mammography rates with staff and training for new staff on implemented processes. This project is generalizable to any preventive healthcare aspect where screening, patient engagement, and referral for treatment with adjustment to the chosen health decision are available. In addition, team engagement needs to occur with staff willing to participate in preventative health promotion. These are my references. I've included a picture of a portion of the staff at Family Medical Center of Hart County that were assisting in this quality improvement project. And at this time, I would like to thank Amy Thomas, my mentor and sponsor, and Dr. Judith Butler, my continuity faculty, for their assistance. And I'm going to have a short facilitated discussion, and I would like to begin by asking if there are any questions. Okay. I know that was a struggle. What suggestions do you have? Can you hear me?
Oh, no, it's good. Your last two slides didn't come up, but you have them, right?
What?
No, I thought it was good. Yeah, what things did you have to change today? That she
just to kind of make things a little more concise and make sure that I was including a lot of the team engagement stuff.
Are you there, huh? Oh, sorry. So I thought the tables were really good. I liked your graphs. Defining right care was good too. That was a good idea. I had not thought of that.
I know I need to practice more, but
yeah. And I like the way you handled talking about your team. That was good. And how you talked about, ways to improve the team engagement. I thought it was really good. Yeah. No, I thought it was really good.
Thank you. Anything you think that I need to?
I also liked the way the one run chart with the standing orders, like the three different. That was really good. How'd you do that?
So I added.
That was really good.
An extra.
Is that hard
column.
to do?
I added an extra column in the run chart. You know, when you had, because it just had the three, like your measure, goal, and.
No, I don't think so.
Value, median, and goal, whatever those three things were. And I added another value.
Mm-hmm. Yeah. Oh, okay. Let's just see if I can figure that out. No, but all your tables were really good. I liked your tables. They're really easy to read and clear.
Thank you.
I thought it was good.
Okay. Mm-hmm. Do you want to go over yours?
No, I have no idea what I'm doing.
Okay. Well,
Can I catch you later on that one?
Yes, when you're ready, we'll go over it. And if you need me to help you do the extra thing on the run chart, let me know.
Okay, sounds good.
Okay.
Well, good luck on Friday.
Thank you so much. Have a good night.
Take
Have fun
care.
on your vacation.
Bye.
Bye.
Okay, thanks, Julie. Bye.